Mr. Tenge is an 85-year-old male presenting today with shortness of breath. It started last night at 11 p.m., just after he had some chest pain, and the chest pain was sharp and it lasted for about 30 minutes. During that time, he was diaphoretic. He didn't try to take any medications or seek out help. It self-resolved, and so since then, his chest pain has not come back, but his breathing has progressively gotten worse. When he lies down, he becomes more short of breath, and when he is walking, even just from the car to the office, it's worse. So this morning he wanted to come in because he says he's just feeling very sick now, and he's concerned. He's not tried any treatments for the shortness of breath, and he's not been seen by anyone else for this, and he says he's never had anything like this before. He's not allergic to anything. He's gotten the flu shot this year, but he's out of date on tetanus, and he's unsure about the pneumonia vaccination. His current medications are only Motrin 400 milligrams twice daily. He doesn't take any prescribed medications or any herbal or supplemental things. Medical history includes arthritis, BPH, and type 2 diabetes that's controlled by diet. Surgical history, he had a prostate revision when he was 55. He doesn't remember details about that. For his family history, he does have some cardiovascular history there. His mom died of heart failure at age 76, and his father died of an MI at age 70, and then his brother has emphysema. He does have 2 sons who are alive and well. Social history, he does not use alcohol and hasn't in many, many years. No drugs, tobacco. He has a 20-year pack history that resolved when he was 30. He quit, but it's still there. Work exposures, he was exposed to chemicals in 2 different jobs in his life, but he's been retired for 20 years now. He's not had any new environmental, insect, animal exposures in the recent past. He walks a half a mile a day. He eats a low-fat diet with 2 cups of coffee a day and has not had any new foods. And he's not traveled in the last 6 months. So review of systems, he is negative for pain, fatigue, weakness, weight changes, any recent injuries or illnesses, HENT. He does have dentures, but he does not have any tender or enlarged lymph nodes. Respiratory, beyond what we talked about already, he does have a cough that started last night, and he's coughing up white sputum. He doesn't have any hemoptysis, wheezing, or pain with breathing. He does not have any nocturnal dyspnea. And then further into his history, no history of asthma, COPD, emphysema, bronchitis, or lung cancer. So cardiovascular, he does have swelling in his ankles, and he is negative for claudication or cold extremities. GI, he's positive for decreased appetite related to the work of breathing, but negative for other items. And then all the way to neurologic, he is positive for some intermittent lightheadedness since last night. Objective, he's afebrile. His respiratory rate is 40. His heart rate is 110. His blood pressure is 160 over 96. His BMI is 20.9, and his SAT is 97% on room air. Physical exam, he's in mild distress, but is appropriate to the situation. Neck, he has no carotid hums or bruits or JVD. His chest is symmetric. He has a 1 to 2 AP diameter. Ventilation is labored. He's using his accessory muscles, and he does have retractions. He does have fine crackles in the bilateral lower lobes, but clear in the uppers. He does have an S3 gallop in addition to the S1, S2, and then he has a 3 out of 6 systolic ejection murmur. And it seems to be irregular just by feeling the pulse and by listening with the stethoscope. Peripheral vascular, his pulses are 2 plus in the uppers and in the lowers, but I did endorse a 2 plus pitting edema in the lower extremities from the ankle down. His abdomen is soft, non-tender. I was able to palpate his aorta, but it's not a pulsatile mass and it's not tender. For derm, he doesn't have any rashes, jaundice, discoloration in his legs, and he does not have any curvature to his fingernails. MSK, I didn't notice any abnormalities there. So for my differentials, considering that he may have had an MI last night, maybe having some residual vessel blockage, congestive heart failure, COPD, emphysema, PE, and pneumonia. So for this visit, I ordered a chest x-ray. The result of that showed the heart was enlarged with a left ventricle predominance. I did an EKG that shows that he was an AFib at a rate of 120. Labs, the CBC was benign, troponin was 1.3, BNP was 560, D-dimer was negative, BNP looked good, hemoglobin A1C was 8.0, and then on his lipid panel, his LDL was just a little bit elevated at 125. I did an echo, which showed left ventricular hypertrophy, an EF of 25%, and an anterior myocardial infarction. The read was consistent with that because of wall motion defect. So for him, I wrote down the cost. So with the echo, that really bumped the cost up, but it was $1,317 for those labs. So I have a long problem list. I have, my diagnosis is myocardial infarction, probably last night. And then since then, he's developing some congestive heart failure that is causing the dyspnea with the EF of 25% and with the edema. He may or may not have been in this arrhythmia before, but he's noticed it only since last night, feeling that heart racing. So AFib, uncontrolled hypertension, bilateral pleural effusions, saw that on the x-ray, uncontrolled type 2 diabetes, hyperlipidemia, left ventricular hypertrophy, ejection fraction of 25%, the murmur, the edema, the pack years of smoking, the unknown vaccination history, the history of workplace chemical exposure, and the family history of cardiovascular and pulmonary disease. So for patient education, at this point, I would send him to the hospital and I would admit him. I would tell him not to go home. I would tell him to just go ahead and go to the hospital. So plan of care, admit. I would do a cardiology consult, do a cardiac cath, get IV started, get him on a monitor, give him oxygen. I would get a hospitalist to manage diuretics, beta blockers, anticoagulation, get his blood pressure down, and get his glucose under control. And then when he's out of the hospital and they've done any stents, interventions, things like that, I would want to follow up within 1 week of discharge. Items to address an outpatient follow-up would be continue the diuretic. I would probably choose Lasix. His kidney function is fine. I would supplement with potassium as needed. I would do an ACE inhibitor. I would do lisinopril. I would prescribe a beta blocker, probably metoprolol. And then if the AFib was persistent beyond antiarrhythmics or things that they do in the hospital, cardioversion, things like that. If this is a chronic AFib, I would choose an anticoagulant, probably a NOAC. And I would recheck labs. I would want to recheck the LDL. If that's still elevated, I would start a statin. Crestor is a good one to start. do some nutrition education with that. And then for diabetes management, I would do some shared decision making based on his GFR insurance coverage and things like that. We could start with metformin. PFTs, I would do that when stable, outpatient. His chest x-ray didn't indicate any COPD or emphysema, but I still would like to get those done. And then discuss the vaccinations. So get an accurate record of his pneumonia vaccine, get an accurate record of shingles vaccine, and if he hasn't had those, I would move forward with getting those when he's better. And then depending on labs and things, I would follow up probably in 4 weeks just to check all of his vital signs and things like that. So for pearls of wisdom kind of stuff, DXR made it seem like the cardiac event actually happened weeks ago, and that this congestive heart failure was kind of leading up to this point over a period of time instead of just from last night. And it seemed like also the echo and those types of things were done inpatient, which is totally reasonable. That's actually what I would do in the real world anyway. I would probably expedite this whole process, and I wouldn't make him go to an outpatient x-ray, and I wouldn't make him do an outpatient echo because these things would take days. So I would get him admitted, get him there. The only other pearl of wisdom thing was the PFTs. I was going to run those, and I decided against it. I thought twice because they use a beta agonist to perform the test. And if you give a beta agonist to someone in AFib and a rapid ventricular rate, especially someone who is hypertensive, you could make their vital signs worse. So that's something I learned there. Thanks.